All right. Good afternoon, everybody. I'm going to go ahead and start. This is a fairly long and complicated topic, so I don't want to run out of time. And I'm going to try to keep you all awake the best as I can. I guess you all know me, so I'm Karina Sulaiman, and I work here in the nephrology section and the section of internal medicine. And I'm somehow your program director. Okay, so my topic is AKI, concepts, controversies, and updates. I don't have any relationships to disclose, and I don't make any money off any trials or anything. So I chose this topic. I like to teach this topic to the students. I like to teach this topic to the residents because I think that it is one of the most relevant topics for the general internists in general to know something about before they involve the nephrologist in the care of the patient, because time and time again we have seen that the amount of time it takes to identify any syndrome of AKI and treat it, that lost time is proportional to their chances of recovery. And so I think this is the best time is when you're in your training to be able to recognize this and do something about it before you kind of call upon the nephrologist. By the time you call upon the nephrologist, you probably have already lost some very precious time, or you've done the appropriate things already, hopefully, and have done good by the patient. So we're going to divide the talk into the definition and classification of AKI. We'll talk about some diagnostic markers that are out there now to try to help refine this definition and the way we identify AKI. And then time permitting, we'll talk about some specific syndromes of AKI. So one of the biggest issues with AKI is that there is no standard single universally applicable definition. Everyone has something else they go by. The nephrologists, as you know, are pretty famous for basically defining things differently and going in different directions with it. And that is because it's quite difficult. We don't have a troponin. There's no cardiac marker-esque thing where we say, oh, this is high, this is AKI. So it's a complex and multifactorial disease. But one thing we do know, which has in the past decade really come to the forefront of literature, is that there is predisposition to loss of long-term kidney function and an independent negative impact on mortality. Practical things are increases hospital length of stay, cost, and then there is this really big study that they did which shows that an increase in serum creatinine of more than 0.5 milligrams per deciliter actually increases your mortality, as well as all this hospital costs and all of that. So the last slide is actually Medicare data that came out a few years ago. So some of us actually believe that we should be taking this as seriously as we do our non-ES elevation MI, and we don't. So that's another reason that I wanted to highlight this. So this was ASN in the Loop is our little newsletter. So this was a headline a few years ago to try to catch everybody's attention. And it was based upon this study where they did a pretty large study of about 37,000 patients admitted to the VA, showing that following them for 6 years and showing that there was more deaths in patients who had both AKI and MI. So that's why, again, this is something we need to really try to watch out for and diagnose and identify early. So our main recommendation body is called the Kidney Diseases Improving Global Outcomes. So we have KDIGO guidelines for everything, and the AKI update was last done in 2012. Defining AKI as any of the following. So you don't have to have all three. You can have an increase in serum creatinine of 5.3. You can have 1.5 times the baseline of the increase, or you can still use the urine volume, which is, to me personally, is my personal favorite, but the only problem with that is that we don't have strict isonos on most hospital floors. So traditionally, we classify AKI as prerenal, renal, and post-renal. It's the way you were taught in medical school, and it's still, I believe, the most reliable way of trying to address a problem if you're trying to just find out what's going on. Out of these, the commonest by far is prerenal, so that's why most of the time residents will see patients with AKI, assume it's prerenal, give them a bag of fluids and see what happens. And there's nothing wrong with that because statistically speaking, you're probably right, as long as you've given some thought to trying to rule out renal and post-renal while you are doing your management of the prerenal. Make sure there's no obstruction, make sure that there's no reason for them to have obstruction, do they have a Foley catheter, and then the way to identify a renal cause, the simplest way is to just simply order urine analysis while you're busy giving those fluids so that you've done all of that so that by the next morning, if you are not wrong about the prerenal diagnosis, you already got some other stuff cooking before you've done something about it. So that's pretty simple criteria, and over the years, researchers have tried to I guess, make it more fancy, make it something that is a little bit more tangible and divisible, I guess. So the rifle criteria came out from the Acute Dialysis Quality Initiative, and they were introduced in 2004. The idea was that if we can get somebody from a F to an I by using some sort of therapeutic or diagnostic maneuver, we can show its utility in practical medicine. The idea wasn't to basically make it practically applicable to clinical medicine. So RIFLE stands for risk, injury, failure, loss, and then ESKD. And it's time-based, essentially, part of it is. So if you've had an AKI for more than 3 months and are dialysis dependent, then you now have end-stage renal disease. I'm just going to rush through this because we don't use it anymore. So the limitation of RIFLE was that any clinical signs of AKI appear only after some time when the GFR has already declined. The whole problem is that by the time the creatinine goes up, the person has been in AKI most likely for some time. The urine output, which is part of the RIFLE criteria, is affected by diuretic use, which remains one of the big problems of diagnosing AKI because you also have all these patients on diuretics, which include chlorothalidone, hydrochlorothiazide, Bumix, and Lasix, and not just Lasix. So you don't really know if your normal urine output that is being maintained while you're on diuretics means that the patient is not in AKI. They could still be in AKI if they're on diuretics. And then small increases in creatinine were not included in RIFLE criteria. If they were below the 0.3, then you just didn't catch them, and they can be significant in patients with much lower baselines. So the investigators were tempted to use the estimated GFR. So all of these creatinine-based values make that equation, which is the estimated GFR, which is not the measured GFR. And then they would use that to say, okay, someone changed from loss to risk, and that may not be an accurate reflection of their actual improvement of AKI. And of course, there's no mention of where exactly this injury came from in RIFLE criteria. So the AKI network, which is basically the same group of people, got together and modified the criteria in 2007 and refined it and kind of got rid of some things and just made it stages 1, 2, and 3, which is still in use, but again is much more applicable in the research arena to try to see if we can get markers that are going to identify people at 1 instead of 3, for example. So they took out loss, they took out ESRD, and they added in the absolute increase in serum creatinine. And then if you're already beginning with dialysis, you're a 3. So I guess it focused more on that severity and made it much simpler for physicians to apply it to patients. So this is the AKIN criteria, stage 1, 2, and 3. So basically, if you start with the anuria, you're already at 3. That's sort of the main teaching point of this. And then the milder your serum creatinine increases, the earlier your stages. You're still having the urine output of less than 0.5 ml kg per hour. So really, you can only use this in critical care settings where you have strict I's and O's. So it still doesn't define the nature of the renal injury, and the diagnoses that are based on the urine criterion alone will not take into account urinary obstruction. All right, so in clinical practice, we basically don't use it too much, and you can't use it in isolation. And there are lots of models out there that are trying to compare RIFLE with AKIN with a clinical model, which are developed in different institutions, individualized. So no one is doing the same thing, basically. And then they're like comparing it to each other and trying to show reliability. So so that's one problem. One big problem is the definition. Second problem is, what is the ideal biomarker of renal injury? Ideally, as we all remember from our physiology, that marker should be metabolically inactive, freely filtered, and not altered during passage through the nephron. That's your ideal marker, and what we use as the gold standard for measured GFR are inulin and iodothalammate. And iodothalammate was the one that was used to derive the MDRD equation that now estimates your GFR in your lab equations. So serum creatinine doesn't fulfill these criteria, and it's the one that we use. So it's a 113 Dalton molecule derived from phosphocreatinine, which you know is a product of creatinine metabolism. So it is freely filtered by the glomerulus and excreted thereafter, but different people have different rates of creatinine production. So this was what was used to develop both RIFLE and AKIN, and is also part of any definition of AKI, whichever journal or group you want to follow. And it's all we have at the moment in current standard practice. Its limitation is that there are a variety of non-renal factors influencing production rate, and it's variable even in your own cells from one time of the day to the next or from one season to the next. Some factors that influence it are age, gender, muscle mass, and diet, and nutritional status. We have a lot of hypoalbuminemic patients that are malnourished, and for whom you cannot rely on those maybe slightly lower creatinines to say that the patient is not in AKI. Also, creatinine is inhibited by medications such as trimethoprim and cimetidine, so we do see those rises in creatinine, and we think that that's AKI, and it may not necessarily be AKI. So this is just a graphical example of what happens, when your production of the creatinine reduces. So at a normal production, you see that your serum creatinine, when there's a 60% decrease in GFR, is that red line. If you don't generate creatinine by 25% decrease, you automatically have a reported serum creatinine at the blue line, which doesn't even fall, it falls somewhere between KD goes stage 1 and 2. So it's very important to keep those things in mind when you assess somebody's BMP on a daily basis as well, to see what their body mass is, what their nutritional status is. And really, it's the trend that matters more than the number itself. Okay, so let's go back to some older markers that a lot of people ask, why aren't we using those still, or what is their utility? So the rate of urea production increases with all of these things. Again, B1 is a marker that is affected by things that are factors other than just renal failure, especially patients who are on steroid therapy. You have to keep in mind that they may have those higher BUN to creatinine ratios, but the BUN goes up with steroid therapy. The rate of urea production will decrease with a low protein diet. So we might see a markedly low BUN, and it doesn't mean the patient is not in renal failure. So it's not a very sensitive or specific marker of AKI. So then comes urine output. This is, as I have said, is more useful in ICU settings. There have been smallish studies of 300 or 400 patients done over the years showing that if you use urine output as your AKI identification, you have lower mortality rates in, again, mostly ICUs, because that's the place you can find it. The issue, of course, is measurement. So this is really the latest thing that came out in 2017, showing, and I picked it because it was a very large study with 15,000 patients. They took a group of patients and they did intensive urine output monitoring, which meant hourly monitoring for more than 3 hours, and they did not do that for the other set of people. So of course, they first of all identified AKI more. There was more AKI in those patients, and you could argue it's because you were able to catch that AKI earlier because you were monitoring it. And then in those patients, because you were monitoring it, you ended up overall with less volume overload because you weren't just shoving volume at them without checking your urine output, and overall a reduced 30-day mortality. So I think this is something as nephrologists we all already know, that we really need the urine output to help us make a decision, and it is something that I think we should push to get done more strictly on the floors. The limitation and the reason we don't use it very often is just that we just don't have it done as strictly as we would prefer it to. And of course, it does require a lot of nursing personnel. Hourly urine output checking is quite challenging, even if you have a Foley catheter, to be able to mark and do. So you have to kind of incorporate that culture into any floor, which requires more hands-on nursing staff. So it is something that I would think is a little unreasonable to ask a regular floor nurse who's a surgical floor to do, unless there was a specific reason for it. Fractionation excretion of sodium, big favorite with ninth floor residents. Everybody gets a urine sodium and a urine creatinine. So its utility is to try to differentiate a prerenal to a renal origin in AKI. If you're already quite confident that this is prerenal, it's not super helpful, but if you are on the cusp of trying to figure out what's going on, has something nephrotoxic happened, is it renal, it is best to get this early before you attempt any maneuver on the patient that will influence that urine sodium later. So value below 1% suggests prerenal disease, but 1 or 2 caveats is CKD. If you already have chronic kidney disease and now you have AKI on CKD, it may not be that reliable because you already may have a low urine sodium. And of course, again, if you're already on diuretics, even if you stop those diuretics at 8 p.m. and they got an 8 a.m. dose at home, that may influence the test result as well. So it's something that you take into account along with the other data and not sort of go by the one thing, the one FINA and say, well, this is what it has to be based on that. So biomarkers, a little bit about the biomarkers. So this huge slide is not meant for anyone to be able to read the details of, but all of this blue stuff are all the markers currently, and actually minus 1 or 2 new ones that are under study to try to find that ideal marker to replace creatinine. And we are just going to talk about a couple of them. So in this slide, these are the top 4 that are really under study right now, and cystatin C is the one that has really stayed. I mean, its popularity has been maintained over the last decade or so as still one of the key players in an attempt to replace creatinine. Rest of them still being studied, and a lot of different labs are basically trying to promote even more. But cystatin C, I think, is fair game for everybody to know because it's already being recommended that we incorporate for chronic kidney disease cystatin C-based equations into our assessment of chronic kidney disease GFR. So I think that it is coming. So it's a low molecular weight cysteine proteinase, and the reason it became popular is because it's produced by all nucleated cells. So the thought was, this is that marker that's released by all cells, it's freely filtered, and it's completely absorbed in the proximal tubule. However, it still can be influenced by the same things: age, gender, weight and height, and also smoking cigarettes. There aren't very large changes. The proponents of cystatin C still believe it is far superior to creatinine. There are larger institutions who are already ordering cystatin C levels. Ours is not one of them, but I think that this is one that we probably are going to get to start to use in the near future. It can be measured as a serum or a urine sample. There is conflicting data on its utility in AKI, although it's becoming more established for use in chronic kidney disease. NGAL is neutrophil gelatinase-associated lipokaline, and it also is urine and plasma measured. Most of the robust data which compares creatinine to another marker, I think the best data out there is really the NGAL. But it's very, very small studies, 50 patients, 60 patients, very isolated populations. The majority of these studies are done in cardiac surgery patients because we see a lot of AKI in CABG patients, and they're a very controlled environment with the ability to do all of this testing and all of this measurement. We don't really see all of these studies done on your average patient that is admitted to a regular floor, so we have to extrapolate a lot of this. So it was identified as a potential marker in 2003. Someone did a huge search for genes and figured out this should be the one we should focus on, and kind of identified and targeted this. So one sort of word of caution, and this is the reason I brought this study up, it's also from 2017, is I really liked it because it actually did kidney biopsies of deceased kidney donors, compared it with their creatinines and with a host of other markers to say, okay, we've got pathology now. Are we actually detecting AKI as we are supposed to in these donors who are supposed to have healthy kidneys when they are transplanted? And in these patients, you saw that, first of all, they were all supposed to be normal. 17% of them had already had mild acute tubular injury on autopsy, and 57 or 10% of them had severe acute tubular injury not identified by serum creatinine. So they tested them against all these other markers, and NGAL demonstrated the best results, essentially, in this particular study. I think it's one of the more reliable ones because it compared actual tissue to the marker as opposed to some of the other ones. So last and latest kid on the block is urinary matrix metalloproteinase. It's very, very promising. They're undergoing studies for it, and again, mostly in cardiac surgery patients. But the cool thing about it, and that's really what I want to focus on, what we want to do eventually, we want to find something that peaks early. Within a couple of hours, it goes up, and we know AKI is imminent. So that's the reason that it's popular. And in this study, which was about 500 patients, if you had a high MMP level, you had a higher risk of AKI, dialysis, and in-hospital stay and ICU stay. So, probably this is, of all the newer ones, this is the one that seems to be the most promising. So this is another study that showed that correlated the urinalysis findings with urine kidney. I'm bringing this up because my favorite test to figure out what's going on with the kidney remains the urine analysis, and it is relatively easy to do and something we should all have at least try to acquire some skill in interpreting, if not doing, which is why I kind of pick on people doing morning report or not a lot, because it's always going to be there, even when all of these markers come and go. So this study basically compared urinary biomarkers of injury with UA findings, and they tested it against NGAL, IL-18, KIM-1, and LFABP, which again, these three really are the ones that are still under study. And what you could see is that if you had hematuria, you had increased levels of all biomarkers. If you had proteinuria, you had increased levels of all biomarkers. So, and you know that all of these things correlate with AKI. So you know basically if you find these abnormalities in a urine analysis and if they are reproducible. The one thing about the UAAs can be somewhat unreliable. So you don't know what time you got the sample, was it a contaminated sample. If you suspect that this is a true finding, just repeat it. It's again not very expensive. And if you have persistent proteinuria or unexplained hematuria, that still is one of the best guides to us that there is genuine AKI, and probably we need to go further in our diagnostic workup. Okay, so that sort of segues into my next way to measure AKI, which is urine microscopy. So it's, nothing will sort of replace the ability to see a red cell cast, for example, where you can find RPG and distinguish between prerenal and ATN. You just look at it, and if you see a lot of casts, you know that there is some tubular injury. And it does improve the differential diagnostic and prognostic evaluation of AKI. None of the others say anything about what the etiology could be, but a urine analysis does. Now, one little practical thing is, if you want a urine with microscopy, you have to order a UA with microscopy instead of ordering a UA. It doesn't reflect to microscopy, and somebody in the lab who is not a physician will decide if a microscopy is needed, which is something I don't agree with. So if you ever order a UA, just order the one that says UA with microscopy, and you won't get into this trouble, because then we come in the next day and we order that UA with microscopy, or we do it ourselves and just waste a little bit more time. Okay, I really like this quote, so I stuck this in to wake a few people up. The ghosts of dead patients that haunt us do not ask us why we did not employ the latest fad of clinical investigation. They ask us, why did you not test the urine? This was actually a radiologist who has a bunch of other really fun quotes that I found on Google. And I guess in those days, you had to be an internist first and then become a radiologist, because he seemed to know a lot more than radiology when you look through his history. And he's famous for Hutchinson's disease. His main area of interest was actually GI tumors and radiology, I suppose. Okay, so we're going to go to syndromes of AKI. So now we know a little bit about the challenges of diagnosing and classifying AKI. I'm going to pick the syndromes that I think are the most commonly seen in internal medicine and are somewhat iatrogenic, because you could go on forever about how many different causes of AKI there are. So I'm going to start with contrast-induced nephropathy. This is one of the commonest causes of hospital-acquired AKI. And it's got a pretty variable reported range depending on which database you look at. And we know that it has poor short-term and long-term outcomes that are not just limited to renal disease. Again, deaths from cardiovascular outcomes continues to be an issue with most AKI-related syndromes if you don't treat it. And the reason I think it's very important, it is the one that's the most amenable to preventive interventions if you identify high-risk patient. And it's a dose-dependent injury. So it's really quite simple. If you lose less contrast, you're going to get less injury. And if you communicate with your radiologist about this, or your cardiologist, and say, hey, I think this patient is high risk, shall we do a test that doesn't have that much contrast, you may actually get into a conversation where you end up not even ordering what you thought you would order, like a chest, abdomen, pelvis CT with PO and IV contrast to find a little nodule somewhere. And they actually have quite a lot of technology and stuff they can do which prevents using contrast if you talk to them a little bit about it. The thing about contrast-induced nephropathy, however, is that it does require about 48 to 72 hours to identify. So people staying overnight to see what their creatinine is going to be the next day is absolutely useless. All right, so what are the risk factors? It's easy to identify contrast-induced nephropathy risk patients if they have CKD. But the ones we don't identify readily are patients with diabetes who already have proteinuria and they have a creatinine of 1. So they are at risk too, just keep that in mind. Patients who have congestive heart failure, any reason to develop acute hypotension, so we know that they are prone to tubular injury. And again, cardiac surgery patients were the model for where we found this problem. ST elevation, MIs, volume depletion obviously, and CKD itself. This is the easiest one. Everybody identifies this and says, yes, we know they are at risk. But you remember the other populations as well, and of course the elderly. The elderly already, they may not have CKD per se, but they do have an age-related decline in GFR, which is normal, but the fact is that they have less nephrons, and so they tend to be more prone to chronic kidney disease. Okay, so what happens is that you get vasoconstriction leading to diminished blood flow, and also direct tubular toxicity of the kidney. So if you know this, you'll see what you'll be able to tell what you can find in a UA. You probably would just find some casts and planned urine analysis. You may find nothing if there isn't too much direct toxicity. So what do you do? The main thing is prevention, prevention, prevention. Hydrate these patients the best you can. It's the most challenging population to do this in is CHF. They've got an EF of 15%, and you need to do that heart cath. And of course, you need to do that heart cath so you can fix that CHF. So I understand that. Maybe doing simple maneuvers like holding AM dose of diuretics, making sure they're not on metformin, making sure they're not on NSAIDs, things like that will go a long way in trying to prevent this. You should use low osmolality contrast, which the majority of institutions, including our own, do use now, which is why we're not seeing this as much as we used to when it was high osmolality contrast. So the two big maneuvers I think that have been debated over the years are N-acetylcysteine and IV bicarbonate. So IV bicarbonate, there was one positive trial in JAMA in 2004, and everyone ran with it. There were many, many negative studies following that, the latest of which I found out this morning was in NEJM in February, where they actually tested patients with one arm was saline, one arm was N-acetylcysteine plus bicarbonate. They had to stop the study in the interim analysis because there was no difference. So there is no difference. You can just use plain old saline and get the same effect. And N-acetylcysteine tastes gross. So that it will make your patient a little bit more happy if you don't use it. The other therapies out there, forced eumolemic diuresis is something that some people have suggested on and off again in literature, but it is not routinely recommended. And we get this question all the time. Can we dialyze this patient? Well, if you're going to get contrast-induced nephropathy requiring it, sure. But dialyzing people preemptively has not shown to do anything good for the patient, for the kidney, or for outcomes. So usually our answer is, well, let's wait and watch and get the study, and then we'll see if they need it or not. And we should not be telling patients that you're going to need dialysis if you get contrast. We don't know. We should be just giving them a risk of what of their likelihood of dialysis is, and then letting them decide. Okay, so we move to cardiorenal syndrome, which is another very common syndrome we see here. It's basically CHF and AKI made fancy. It's when you have coexisting cardiac and renal dysfunction. And you could have the renal dysfunction causing the cardiac failure or vice versa, and that's how cardiorenal syndrome is staged. Again, it's important because we know that if you have CHF plus AKI, you have worsening outcomes, so you want to address them both while they're in the hospital. So you get impaired cardiac output, which causes renal arterial underfilling and eventually reduces the GFR. So of course, if you do something about their cardiac output acutely by giving them diuretics, you should theoretically improve their renal blood flow as well. So this is the classification of CRS, types 1 through 5. What basically you need to know is the 1 and 2 is when there's actually a problem in heart and causing AKI, and 4 and 5 is, 3 and 4 is essentially the problem started with the kidney and then caused heart failure, and 5 is that you have combined dysfunction that is so severe it's pretty difficult to tell which came from what. One thing that I wanted to touch upon, because again, this is something I get asked a lot on rounds, is this concept of diuretic resistance in cardiorenal syndrome. And why are we choosing 120 milligrams of Lasix on these patients as a last-ditch effort before we decide that they need dialysis? So the problem is that once you have cardiorenal syndrome, you should respond to diuretics, but you're also at the same time activating a lot of mechanisms that are causing simultaneous resistance to these diuretics. And eventually your RAS system, just to keep this as basic as I can, gets activated to where your preload gets increased. So it's just going against itself, and you need to keep on giving diuretics to get over that hump, essentially. You also have increased beta-adrenergic activity when you have CHF, which also causes salt and water retention. And then if you have progressive decompensation, all your autoregulatory mechanisms decide to decline. So your homeostasis basically stops working. Now you've added loop diuretics to the mix, okay? So you give them their loop diuretic, and they get activated in the proximal tubule. So if you don't have healthy tubules already, so if you have some CKD, then you're not going to get the response you want from the loop diuretics, okay? And you get hypertrophy of these tubular cells with chronic diuretic use. So that's why we kind of take them off, put them on, take them off, put them on. You've seen that happen a lot. So what is the main way to avoid diuretic resistance? Unfortunately, it's fluid and salt restriction. So that's why it's very, very important to counsel the patients on this, because you're not going to get your best bang for buck in diuretics in any condition if you're also not salt restricting. You can give them all the Lasix you want, and when they don't salt restrict, it doesn't work. And it's usually a patient-driven factor. So that's something to keep in mind. Eventually, you use diuretics, it doesn't work, you can try vasodilators, and as we've seen in patients, sometimes that leads to hypotension. If it leads to hypotension and you're needing a way for them to be able to breathe, you can go to continuous positive airway pressure and inotropes. This is the point where I usually come in and say we need to put them on some sort of an inotrope drip and continue those diuretics. And I think this is something we should be doing more often in order to avoid getting them on dialysis than we do. Because ultimately, of course, we can dialyze them and take the fluid off safely as long as the blood pressure is not too low. Okay, we got time. So hepatorenal syndrome. This is a volume unresponsive refractory prerenal azotemia. And the major pathophysiology is systemic and splanchnic vasodilation, and that leads to renal vasoconstriction. But there is no renal parenchymal injury. So it's pararenal if you biopsy that kidney and the kidney was normal. It is a diagnosis of exclusion. You don't call every cirrhosis that comes in through the door with AKI hepatorenal syndrome. You have to exclude other causes as you would in anyone else. Divided into type 1 and type 2. Type 1 is doubling of the serum creatinine within 2 weeks, so it's more rapid basically. And type 2 is the one that's a lot more difficult to diagnose because it takes longer, then you already have patients on diuretics, they may also have a UTI, and you want to be able to exclude all those other things before you tell them they have type 2 HRS. So it has clear-cut diagnostic criteria. You have to have cirrhosis with ascites. The only exception is very severe acute fulminant hepatic failure that has caused ascites or a cirrhotic type picture. But majority of them have actually cirrhosis. They don't have mild hepatitis and then they're getting hepatorenal syndrome. The serum creatinine needs to be more than 1.5, and most importantly, you've got to withdraw their diuretics and give them some albumin. This is the one time I think albumin is actually indicated and we should do it, and see what happens. Now, keep in mind that you can't give everybody 1 gram per kilogram body weight of albumin unless you want to drown them and have them die, which we actually have had a poor outcome related to somebody trying to follow this and not tapping the belly. If you're going to give that much albumin, you probably have to tap the belly as well so that you avoid fluid overload. These are the guidelines that we have to keep them in mind, keep patient safety in mind. We shouldn't have any other cause explaining it, so shock or any parenchymal kidney disease. Now, we're not biopsying these patients to say that there is no parenchymal kidney disease. So at the very least, again, we get that urine analysis and we show that there's no proteinuria, there's no hematuria, there's a reasonable chance that there is nothing going on with your kidney itself. Get an ultrasound, all the basic stuff, and if it's all normal, then you can suspect it. All you can really do for hepatorenal syndrome is try to maintain euvolemia and avoid diuretics, which is difficult because then what do you do about their ascites? So you might send them for TIPS procedures and things like that to try to minimize diuretic use. You can use vasopressors, all of these things, midodrine, but we usually use them as a bridge to transplant. If we think that they have hepatorenal syndrome, we start talking transplant if we can. If they meet criteria, if their insurance allows it, depending on where you're going to live and practice. You can also use, again, extracorporeal albumin dialysis. It's been done in our ICU before, but usually, again, in patients who are on their way to go somewhere else for a liver transplant, and you're keeping them alive in the meantime. Terlipressin is a vasopressin analog that is the most studied, but unfortunately not available in the United States, so we don't use it here, but it is used in Europe. We hope that it comes here soon enough. So this is a little table just to highlight that when you have a hospitalized patient with cirrhosis, your commonest cause is still prerenal. So you're still probably just dehydrated. And then if you don't have any of these, then you start thinking. I just see a lot of documentation about possible HRS the minute a patient has cirrhosis and AKI. So that's something that we kind of want to get away from and rule other things out before we say that. And then this is just a sort of revision of how you get HRS and what you should do for them. Basically, what you need to do for them, again, is all of this, the albumin mostly, and then you basically need to try to get their pressures up and get them into a transplant facility. So allergic interstitial nephritis. This is also very common, as you know, in our hospital or in any clinical situation because it is something that we do to the patient. The triad of fever, reaction, eosinophilia that has been in textbooks since time immemorial is quite rare, it is maybe about less than 10% of patients. So if you see a rise in creatinine, really go back to those medication administration records and see if you started a drug that may have caused this. You do have unexplained fevers pretty often, so you think the patient is infected, but they may actually just have a drug reaction. But if you see these three things, I've seen the rash twice myself in AIN. So if you see them, then you can pretty much rule it in. Another thing I would caution you is that we actually do a lot of CBCs with diff left, right, and center, and don't look at the diffs, especially the eosinophils. We look at the neutrophils and we kind of stop. So if you think that the patient has AIN, go back a few days and see if those eosinophils have been rising. And you might get the answer there without doing fancy diagnostic studies. The commonest causes are antibiotics overall and NSAIDs. So in that category, the main culprit is penicillins. And our penicillin derivative of choice here is Zosyn. So a lot of times we do see a lot of Zosyn-induced AIN. Not to say that it's a bad drug, but it is quite allergenic. So keep that in mind, whenever you see AKI and patients are on Zosyn. At least, even if you renally dose them, so there's also some confusion about nephrotoxicity and allergy. Some things need to be renally dosed because in high doses they may be nephrotoxic. But if they're allergic to them, then any dose of them is bad for you. And so Zosyn, for that, you have to kind of, for Zosyn, you kind of have to keep both things in mind. One other one I wanted to highlight is the PPIs. So of course, as you know, when I was a resident, it was around the time when everyone decided that we had to use a PPI on every patient or we got into trouble, and I'm not kidding. So of course, when you start overusing something to this degree, you start to find problems with it. And a few years later, it turns out that you can get a lot of AIN with it. So one simple thing to do is not GI prophylax, but if you again see the creatinine rising, you might want to switch to an H2 blocker and provide, comparable benefit at least. All right. So this is just the pathology of AIN. You get an increase in interstitial volume. It is a completely interstitial disease if it's acute. It only starts spreading to other parts of the kidney if it's sustained. And the glomeruli are generally spared. If you see eosinophils in the biopsy, then it's probably antibiotics. So if you want to ask the pathologist, did you see those eosinophils, it gives you a hint that it could be antibiotic related. So again, eosinophils in blood and eosinophils in urine. So your regular urine analysis will just show white blood cells because it doesn't stain for eosinophils. So if you see those white blood cells without leukocyte esterase and nitrites, order your right stain. That's the one we do at UH. You might see some proteinuria, but it's very, very mild usually because this is not primarily a glomerular disease. And going back to your BMP, because this is a tubular interstitial disease, you might see slightly low bicarbonates with a non-anion gap metabolic acidosis. That indicates that there is an interstitial disease going on in general. So usually you take a history and you may give them some steroids, and this is where the current sort of controversy is, when to biopsy them. So we used to not biopsy them very often until we got the urine right stain, stopped the offending drug, things don't get better, a week or two later we call nephrology. But it's been shown that the earlier you give them those steroids, the better their outcomes is. So we are encouraging patients to get biopsied earlier now, even if we have a cause, just to confirm it and to try to get these patients treated with steroids, because we don't want to start steroids without that biopsy, or at least I wouldn't. All right, so that's the stuff you do. These are the doses of steroids that you recommend. A lot of people start off with just prednisone if it's not too severe. The dose and the route of administration depends on the severity of the AKI. And of course, there are immunosuppressants as well that you can try if the steroids don't work and you are convinced this is AIN. All right, so abdominal compartment syndrome. Very underlooked for, I think. We have a lot of patients with tense ascites from very many reasons, cirrhosis as well as nephrotic syndrome. Sometimes you just can't find a cause, and it's usually, it can be just the pressure, the anatomical pressure that it is causing. So intra-abdominal hypertension is defined as more than 12 millimeters of mercury, and with new organ dysfunction and more than 20, it's an abdominal compartment syndrome. It's associated with higher mortality and was originally identified in surgical patients, but now we really are seeing this in medical ICUs and medical patients as well, as it's relatively easy to rule out. You can just get a bladder pressure and see what it is, and that will sort of give you an answer. So we are actually fortunate to be able to do that, and we should do that as often as we can to make sure that we have ruled it out. So if you give patients large volume resuscitation, that is actually a risk factor as well, so keep that in mind when you're bolusing them. And sometimes you have to do all these things. You just have to keep in mind that you should look for it, because then if you don't relieve that pressure, you can do any number of maneuvers, but the AKI will not improve. So you get decreased abdominal perfusion pressure, which leads to decreased renal plasma flow, and eventually you also get a rise in your catecholamines, and the intracapsular pressure goes high, and eventually when you don't fix this, you're ending up with ischemia. And then you're calling us and we're dialyzing them. It really is too late by then. So you first start seeing, again, a decline in urine output, and sometimes a worsening of the ischemic injury, and the diuretics aren't working. So proactive screening and a high index of suspicion has to be there. So you measure the intra-abdominal pressure by using urinary catheter. It's really not very difficult to do, and a lot of nurses are trained to do it, and a lot of them aren't. So you kind of have to look around the floors to see who can do it, and make sure you're very clear about what you want. What's the treatment? If you can, tap them. Paracentesis, nasogastric decompression, avoiding excessive fluid resuscitation. Ultimately, we do end up going to hemodialysis reasonably often if these things cannot be achieved or haven't been achieved in time, and now you have complete anuria. And in the meantime, try to still relieve that pressure and see if we can get some of that AKI back. So in summary, as I've shared with you, there is a difficulty in identifying AKI quickly and accurately, which leads to significant problems in patient care. And that's why we kind of need to just stay as vigilant as we possibly can stay. Just a few updates on the new biomarkers of AKI that are showing promise. I think the most promising of them is cystatin C, but we do need to do further research to understand the performance of these tests, and that research is underway right now, and hopefully within the next decade or so, we'll get better at being able to diagnose and treat AKI. But the emphasis needs to be placed on the prevention. And if you can prevent it, it's way better than getting to the point where you're actually having to refer yourself to all of these diagnoses and try to get that renal function back. So primary care providers should familiarize themselves with the common syndromes of AKI and take timely measures to protect renal function. These are my references. That's it. Any questions?
One comment. Hyperthyroidism with normal renal function, we often see creatinines of 0.4, 0.5, 0.6. In hypothyroidism, creatinine goes up. Not a lot, but maybe 0.3, 0.4. And we've seen patients in the hospital with severe hypothyroidism being treated for AKI when they don't have it.
So, I mean, I would anticipate that that treatment is IV fluids usually, or like a complete workup.
When they're in the hospital?
Yes.
Usually they're being forced with fluids, yeah.
Is there a correction? This is just a sign. Like
mechanism is very obscure. No one's quite sure why.
I have a naive question. When you tell patients to restrict salt, is it added salt or is it the hidden salt? And then what do you tell them about the hidden salt?
So I tend to tell them start off with no adding salt, obviously. If a lot of our patients, they're not able to cook or buy fresh vegetables and fresh fruits and make them. So if they're going to go for instant foods, that they should avoid canned foods. That's really one of the biggest culprits. So I'll kind of direct them to the frozen aisle. It's not the best, but it's better than canned. If you look at the sodium concentrations of all your frozen meals versus your canned, you're going to do better by getting a frozen meal than you are by canned. So I usually try to give them practical suggestions that they can actually follow. And then all this, they tell me, well, I'm on DASH diet and the low sodium stuff. The problem with that is, at least for our renal patient, is that the preservative being used instead of the sodium is generally potassium or phosphorus. So you just want to stay away from everything canned is where I start in terms of what you call the hidden. The only way to really not do salt is to cook fresh meat and vegetables yourself and not put anything in it. And it's just not practical for most people, I would say, every day of the week. So if they sort of follow that kind of advice, it helps a little bit.
One area in the hospital that we get a lot of consults for is the oncology. There are lots of drugs and tumor lysis syndrome.
Yeah. So I think one of the two big things with oncology, I would say for me, is hemolysis syndrome, for which again we have hydration, but also we do have uricase. So if we can prove it, we can get a uric acid level. There were just so many syndromes that I wanted to stop after some syndromes. But the other one is cisplatin. So we do get a lot of, if you see patients that are on cisplatin, and I know that the cisplatin patients actually sign a really detailed consent about renal failure and everything, they get rehydrated. I mean, the oncologists do everything they can to prevent that toxicity. But unfortunately, it is a very effective chemotherapeutic drug. We use it a lot, and we see that tubular toxicity. And a lot of the times, the tubular toxicity is irreversible. Once it's happened, you really just have to keep on replacing. And the hallmark for the residents would be that you start seeing hypokalemia, hypophosphatemia, all the electrolytes start falling while your creatinine is going up. And ways to prove this really, if you check it in the early stages and you check a urine K and a urine phos, they will be high. But many times we check it once they're in advanced renal failure and they're not high. And so the residents are like, well, it seems like they're not losing it through their kidneys. But unfortunately, there's such advanced renal failure now that is interfering with the interpretation of that urine test. So it's also, and thank you for reminding me, one little thing which I do always tell the resident is please replace these electrolytes to where they're normal. And it's not just sort of we like to see a K of 4 and we like to see a phos of 3. The more hypophosphatemic or hypokalemic they are in the setting of AKI, the worsening your tubal injury is going to be, because the tubules that are already now working to try to reabsorb all of those are going to get more prone to tubular necrosis. So be aggressive about those replacements. What's the worst that can happen? It will be 0.1 over the recommended range in the morning. You can stop it. But I do see a lot of hesitancy to use doses, and we always come in and we're like 60 TID of KCl. What is this 40 daily? And that's where this comes from, because we're trying to protect the tubules that are still not damaged.